Pains of all kinds, acute and chronic. How does it happen? Neuropsychiatrist Dr. Saad Shakir will explain that to us and tell us about some things which can be done for relief. Stay with us. Dr. Shakir has trained and worked in many medical fields. He's founder and chief officer of Silicon Valley TMS with multiple offices in the Bay Area. Welcome, Dr. Shakir.
Thank you. It's a pleasure to be with you again on this beautiful spring day.
Now, tell us about the kinds of pain there are.
So pain is suffering to anyone who experiences it. And the area of the nervous system research has been tremendously advancing by leaps and bounds. So there are different types of pains. There is central pain, there is peripheral pain, there is somatic or visceral pain, and we now see a huge connection between the nervous system and everything that contributes to pain, which I will be glad to address during this interview.
Well, one thing I want to know, I don't know if this is an appropriate time to ask about it, but why are there different kinds of pain, like from a burn or a cut or sharp pains or dull aching? Why are they different?
So it depends on the cause of the pain. Mm-hmm. If you have a trauma that interferes with the nerves in, let's say, your hands, you will have a certain characteristic of the pain. But the pain then is transmitted through nerve fibers from the site of the pain to the spinal cord. There's an area called the dorsal horn of the spinal cord, which recognizes the pain signal and relays it across to the other side, up a pathway called the ascending pathway, which is the pathway that delivers the message to the brain. The brain appreciates that signal, recognizes the pain, and then sends a signal back on a pathway called the descending pathway to modulate. Like if you're hurting and you're touching a hot stove or something, your signal, your message is to pull off your hand. It happens very quickly. So that whole pathway is the basis of the new research on interventions for cause and treatment of pain.
So that's involving the nervous system then? Or?
That's correct. So now when you look at the nervous system, it's no longer just the central nervous system, because there are nerve fibers in every millimeter of the body, and those fibers have neurotransmitters, which are chemical messengers that regulate transmission in the nervous system, and they talk to each other until the message is delivered to the brain.
Now, can they malfunction?
Yes.
And what would cause them to malfunction?
Well, there are many. Depends on the kind of pain. So there could be, if you have a trauma, like a regional pain syndrome. So it usually follows a trauma of some sorts. But it interferes with the microfilaments of the nerve fiber, creates a local inflammatory response. That is recognized peripherally, but also there are some chemical messengers. There is research now on a messenger called substance P. There are receptors called NMDA receptors. There is serotonin, norepinephrine, dopamine. So these are the circuits in the nervous system that talk to each other and appreciate pain, recognize it, and modulate pain.
So then if they would malfunction, does that affect the whole nervous system?
So if you look at the peripheral fibers that are interfered with, that cause the pain. So intervention could be only on a local level. However, the spinal cord could have an injury. The spinal cord area that appreciate pain could be impaired. Or the brain centers, the central nervous system, where pain signal is appreciated, is heavily regulated by serotonin, norepinephrine, dopamine, NMDA receptors. So if there is an interference in the central area, you can have peripheral pain, but it's modulated by central pain mechanism, the so-called central pain syndrome. There's peripheral pain, there's central pain. For example, if someone has a stroke in an area of the brain that regulates pain, let's say in the motor cortex of the brain or the sensory cortex of the brain. They can have pain in the right side or the left side depending on the area of the stroke. But the cause of it is neurotransmitter in the central brain that manifests peripherally. So that's central pain. On the other hand, if you have a peripheral pain syndrome like CRPS, central reflex pain syndrome, there are different types of that, but that follows usually a local injury or trauma that can result in a local inflammatory response. But the message is sent to the spinal cord and the brain. So, but the cause is peripheral disruption, which is why sometimes, you know, people use anti-inflammatory agents to try to control the peripheral pain. So it really depends where the signal is and where you want to disrupt the message signaling to the brain.
Well, certainly complicated. Well, what are some common chronic disorders that have pain that you can maybe tell us what causes some of those? And
well, this is $1 million question. There are definitely different kinds. So let's start with headaches and migraines. So those are very common causes of disruption in a person's life. Those are related to mechanisms in the brain area, in the head area, and related to serotonin transmission or epinephrine. So chronic pain, headaches is an example. There is fibromyalgia, which has gotten a lot of press in the past 2 decades. Fibromyalgia, we call it a centralized sensitization disorder, which means a person who you touch, let's say, or they have a painful signal in the peripherally. The message in this spinal cord area is amplified by the calcium channel, NMDA, and possibly the P factor. So when delivered to the brain, it's magnified. People say, oh my God, this is horrendous pain compared to someone who doesn't have fibromyalgia. So it's a neuromuscular dysfunction. And people become very sensitive to pain signals as well as other stimuli peripherally, what's called allodynia, which is sensitivity to touch, other stimuli. So fibromyalgia is a sensitization disorder. The area in the brain, I have a brain with me here. So if you look at the brain, this is the right and the left lobe. So in the left area of the brain, in the motor cortex is approximately here. So the prefrontal area of the brain on the left side is the central area that recognizes the peripheral fibromyalgia pain. So what we discovered is when we treat depression, sometimes with medications or more recently with magnetic stimulation, what's called RTMS, you actually modify the central pain recognition area. And I've had patients who had depression and fibromyalgia who come back and say, you know, I feel the signal, but it doesn't really bother me. And it's amazing. So we basically change the central recognition of the pain in that area. But there's also a lot of peripheral mechanisms to help with pain that I can talk about now or maybe later on. There is nerve blocks, there is intrathecal pump, there are stimulators that could be implanted. So those are more appropriate for what's called neuropathic pain. So neuropathic pain could be caused by a trauma or could be caused by an unknown condition that people suffer and live with.
Did want to ask you about arthritis. That's more of an autoimmune illness, isn't it, rather than something that would be affected by the nervous system?
So arthritis means an inflammation of the joint. There are all kinds of arthritis. The autoimmune one you're referring to would be more like rheumatoid arthritis or lupus arthritis. But there are some traumatic arthritis too. For example, athletes who injure the same joint over and over are going to be prematurely develop arthritis. Let's say knee or hip. You can have an inflammation. Age can cause arthritis, you know, with wear and tear on the joint. So the signal of the pain with arthritis is delivered to the pain in the same way regardless of the cause.
Okay.
So it could be autoimmune, it could be traumatic, it could be inflammatory. So there are all kinds of reasons for pain and arthritis.
I'm kind of intrigued with you talking about touching the skin and being uncomfortable to people. That's a neurological thing that happens to some people, or is it just with the fibromyalgia?
Fibromyalgia is part of a syndrome. A lot of individuals, I call it, this is my own term, the sensitive brain syndrome, sensitive nervous system syndrome. So commonly in fibromyalgia, people can have other sensitization disorder. For example, migraine is very common. Migraine, intolerance to extremes of temperature can happen. They can have irritable bowel syndrome, which is a very common disorder. So that will be sensitization in the gastrointestinal network of fibers. One thing of interest is the serotonin and norepinephrine circuits. About 85–90% of them are in the gastrointestinal tract. So if those areas are impacted, people have nausea, they have cramping, they have diarrhea, they have constipation, depending on the kind. So fibromyalgia can be associated with pelvic pain, very commonly in women, pelvic pain, menstrual irregularities, TMJ. So there are a lot of syndromes around the painful, sensitive nervous system, and often they coexist.
We have one of the members of our television crew has serious fibromyalgia, and we actually have a little video clip that we'll just show that right now.
I've suffered from fibromyalgia for the past 11 years. Back in March of 2006, I went in for a routine surgery. Then around May of 2006, my body started failing me. I was in so much pain and I didn't know what to do. And he said, well, that's a syndrome that affects your nerves and muscles. I'll wake up in the morning and I'll have a lot of energy. Then by around 3 o'clock, my body and my mind starts failing me. I have trouble focusing. And then by 8 o'clock at night, my pain just goes right through the roof. One side effect from fibromyalgia is irritable bowel syndrome, IBS. It makes it very difficult to travel, especially long distances on a plane. You're making constant trips to the restroom. My primary doctor approved me to go to a chronic pain program. So it won't get rid of your pain, but it helps you manage your pain. And you have your own psychiatrist, psychologist, case manager, and pharmacist. It's a wonderful program. They offer a lot of support. When I first was diagnosed with the fibromyalgia, I didn't feel like I could do anything. I was very depressed. I felt worthless. But now, you know, I'm president of 2 groups, and I try to stay busy the best I can. And you know, I have all the support from my friends and my family.
Great, that is fabulous, and I'm glad you can show the audience that. I wanted to say though that it's interesting because he's a male member of your staff. Fibromyalgia is commoner in women. 85–90% of cases are in females. And there is now research on genetic predisposition. I have, for example, a mother who was diagnosed in her 40s, now her teenage daughter is manifesting some of the symptoms. So once we know the diagnosis, we can diagnose it much earlier. Often it's diagnosed between 35 and 50 for the first time.
Have we covered central pain syndrome? I know you talked about central pain. Have we already talked about that?
I probably want to shed a little bit more light.
Okay.
So when you have someone with central pain syndrome, you really need to investigate fully what the cause of central pain syndrome is.
So there's an actual diagnosis of central pain syndrome.
It is, and it's more like a syndrome, if you will, but it follows lesions in the nervous system, in the central nervous system. For example, if somebody has multiple sclerosis, or Parkinson, or dementia, or stroke. So those will be the primary cause of the disruption of the nerve fibers, but the person experiences them peripherally. As I said earlier, if it's in the sensory part of the brain, you're going to feel it usually like, let's say the stroke was on the left side, so you're going to feel it on the right side of the body because that's the area impacted. So that's central pain syndrome. And often the treatment is addressing the mechanism that causes it, if you can. You know, like if you have a stroke or if you have MS, you treat those conditions. And I'm going to talk about what do you do for the pain itself. So there are a variety of ways to deal with the pain also.
Well, maybe after we've talked about all the different
Yes.
kinds of pain, then you can give us some ideas of what can be done.
Absolutely.
I wanted to ask you about complex regional pain then.
Yes. Complex regional pain is the peripheral pain.
Okay.
So that's the type that affects myelinated or unmyelinated nerves, so the nerve fibers. It usually follows a peripheral reason, like a trauma usually. The trauma might have injured a nerve fiber, and it creates a local inflammatory process. You can have sympathetic changes in the nervous system. It can affect the discoloration of the skin. It can cause swelling. And it could be really a nightmare to live with CRPS until we figure it out and treat it. People have some chronic issues with it.
Residual pain and phantom pain.
So phantom pain talks about the area that are either congenitally absent, let's say somebody is born without a limb, or following amputation. That's often seen a lot in war and trauma. So if you have an amputation, what happens in the area, let's say your arm is amputated, there is a neuroma that affects the C nerve fibers. And even though the arm is removed, that neuroma continues to send signals to the brain area as if the arm still exists. And people feel phantom pain. So that's phantom pain. Mm-hmm. Or it could follow congenital absence of a limb.
So you can be born without a limb, but you can feel a hand that you never had?
Pain in the hand you never had.
Really?
Mm-hmm. Mm-hmm. That's, again, nowadays you don't really see a whole lot of that, but earlier in the 70s and 80s, there were people, thalidomide babies, who were born with absent limbs. Mm-hmm. So that was very common then. But now we see it mostly in the context of amputation, either from trauma or from severe diabetes or other causes, where somebody goes through an amputation. So when the limb is removed, there is still a pain signal that's sent to the brain. So that's what phantom pain is. It's localized.
And then, like neuropathy and neuroma, those are neurological as opposed to circulatory problems then?
Not necessarily. Sometimes neuropathy could be from circulatory problems. Neuropathy means an inflammation of the nerve, peripheral nerves. Mm-hmm. So diabetes can cause neuropathy. Herpes can cause herpes zoster, which is the shingles, can cause neuropathy, diabetes, injury, endocrine issues. For example, if you have severe thyroid deficiency or if you have Addison's disease. So neuropathy means pain in the peripheral nerves.
Okay. And psychosomatic.
That's a fantastic
field. That's a
field.
big deal.
Yeah, so that's really one of the reasons I do what I do. I trained medicine, neurology, and psychiatry. And 30, 40 years ago, there was a segregation between the different systems. My philosophy has always been the brain, body, and nervous system work together. We just hadn't figured it out. So a lot of what we do now is see what the connection is. So psychosomatic, or sometimes more scientifically called psychophysiological. An example would be, let's say you go through an emotional difficulty or depression or anxiety, which is an imbalance in the central nervous system. However, the nerve fibers that connect with your gut, let's say, may cause excessive secretion of acid in your stomach, and you develop a peptic ulcer. That could be psychophysiological. Or you can have irritable bowel syndrome, or you can have changes in your bowel habits. So with a central disturbance, psychologically or psychiatrically, can affect body functions. There's another syndrome called somatopsychic, which is sometimes used, which is when someone has an illness of some sorts, and they have a tendency to overreact to, let's say, a pain signal. Every time they get a signal from the pain in the peripherally, they start worrying that it's magnified, similar to what I said about fibromyalgia, but it's more like their interpretation of that signal as somatopsychic.
They become very emotional.
They become emotional, irritable. They run to the doctor, thinking they have, it's now a brain tumor or a heart attack or something more dramatic. So it triggers the anxiety circuits in the brain, and people start magnifying it. So it's not, I smile when people say, oh, it's all in your head. I say, well, it's in your nervous system, not in your head. It could be in your peripheral nervous system, central, but they really talk to each other, and it's important to recognize we can modulate and affect and give relief to a lot of patients by knowing that.
Well, I'm thinking about like hypoglycemia. I know that's something in your I think your pancreas is involved in that. I'm not sure. I know that sometimes they have ups and downs that affect their brain. They can even get a bit psychotic with it. And that would be stemming physiologically, that would affect them mentally then.
Yeah, well, thank you for bringing that, because I remember a famous case when I was in training in medicine. I had a nurse in an intensive care unit call me saying this person is tearing up the intensive care, really violent, really angry, maybe he's psychotic. And I quickly ran over and recognized this guy looks like his history is of diabetes. And he was going through a hypoglycemic attack from insulin he took. His blood sugar was like 7 or 8. I mean, he was almost dead. And he became viciously violent. And then, you know, it occurred to me, I'll give him a glass of orange juice. And he was the nicest person after a few minutes, because we corrected his blood sugar dropping. So bringing the science. So hypoglycemia. So the pancreas secretes insulin. Insulin, excessive secretion can drop blood sugar. And then that can affect the circuits in the brain that regulate mood and behavior. So people can develop all kinds of central nervous system issues from a drop in blood sugar, for example. So it regulates the cytokine system, the immune system, the pain receptors, the mood issues. So sometimes that's why we need to know the whole body when you treat someone who's having those issues. Because had I assumed this person was schizophrenic or psychotic, I might have locked him up rather than give him a glass of orange juice. Similar with thyroid issues, similar with hormonal changes.
Okay, so we'll talk now about pain management.
Yes.
First, how about holistic treatments? Acupressure, acupuncture.
Let me say, the best way to treat with pain is look at the person who has the pain. The biggest problem would be to look at it as if it's a peripheral syndrome and there's an epidemic of opioid use. Mm-hmm. A lot of patients go to emergency rooms, and rather than looking at the whole person, they get a prescription for opioids. And that's the worst thing you want to do. So in our practice, we always emphasize the person behind the pain and what's causing it, whether it's hormones, whether it's depression, whether it's anxiety, whether it is actually a traumatic event in the peripherally. And then a lot of the things you mentioned, for example, fibromyalgia, when I give talks on that, I'd say, listen, you think it's only medication? No, wrong. Actually, the research on opioids in fibromyalgia is zilch. It's not good. It's not beneficial, not to mention the risks of dependency on it. Some of the medications we use for fibromyalgia are more modulating the nervous system. Remember, I talked earlier about the ascending and descending pathway. So some of the commercials you see on TV with pregabalin or Lyrica, gabapentin, they work on the calcium channel in the ascending pathway. And the descending pathway, for example, the older antidepressants, amitriptyline. I mean, I trained in neurology before going to psychiatry, and I can't tell you how much tricyclic, the older antidepressants, are used in small doses like amitriptyline, nortriptyline, imipramine, because those regulates the signal in the descending pathway, which includes serotonin and norepinephrine. Now we know about the central modulation, and I'm happy to tell you in a previous series I talked about transcranial magnetic stimulation. Mm-hmm. So modulating with magnetic stimuli in the brain can decrease peripheral pain also. All that said, there's also peripheral interventions for pain that can be helpful. For example, if someone has complex regional pain syndrome, sometimes doing a sympathetic block in that nerve can be very helpful. And we have an anesthesiologist who can provide those services, and they're less invasive than more surgical interventions.
This is like you would go to a pain clinic. Is that what you're referring to?
Correct.
So they actually sometimes anesthetize the people, and
they do nerve blocks. They use local anesthetic remedies, or they go further up. You know, there's also a device called that's implantable in the spinal cord stimulator, where if someone has a limb pain, let's say. So that stimulator is implanted surgically and decreases the pain signal going to the brain. And then, of course, there is central interventions that I talked about earlier. So you really need to look at what kind of pain. And don't forget about nutrition. Don't forget acupuncture, acupressure, massages. Hypnosis. These are all tools. Cognitive behavioral therapy, which is used often by psychologists and psychiatrists.
You mean psychotherapy? Or?
It is a kind of psychotherapy, but it's a therapy geared to lessening the intensity of the central signal. For example, if a pain comes from my hand, the technique would be to stop that thought, recognize it, and not overreact to it and say, no, I'm not going to let that control my thinking. Take a deep breath and maybe do something similar. So behavioral techniques. Tools. So we are great believers in a multi-pronged approach in handling it. And the bottom line is to help people relieve the pain and suffering that they have and fix. If there's a fixable condition behind it, you know, like if you have a thyroid issue or if you have a metabolic issue, we try to fix that with experts. But we also can modulate the pain pathway and signal at any level I mentioned. Peripheral, spinal cord, or in the brain.
Well, that's a lot to learn in one interview. And thanks for explaining some things to us.
Pleasure. I know I gave you a real bird's eye overview, and I apologize if it's too much, but it really gives you an idea. Don't look at the peripheral signal, only look at how it fits in your lifestyle. The other thing we didn't really touch on is how it affects your life. I mean, for example, there are some people who become really disabled and unfunctional. So can we modulate that? Can we modify their ability to function maybe in another capacity? So that's part of the rehabilitation management of pain.
Wonderful. Well, thanks for coming again.
My pleasure. I'm delighted to be here with you.
Thank you for joining us. Come back again.